All right, so the last topic I want to address tonight, which we've also received a lot of questions about, is the use of ACE inhibitors and angiotensin receptor blockers, or ARBs. Both of these are classes of drugs used very commonly to treat high blood pressure. You might ask, well, why is this of interest? It comes down to something that was observed about 15 years ago, which was that coronaviruses, and this was, of course, before we were looking at the SARS-CoV-2, but this is looking at the first coronavirus that caused SARS. Part of the way that they gain access into cells is using these ACE2 receptors. And of course, a few weeks ago, as more and more attention turned over to the current virus, it also became clear that that was a potential portal of entry. It's still not entirely clear if it's necessary and sufficient, or just necessary but not sufficient, or I doubt it's sufficient but not necessary. Nevertheless, it spawned a lot of questions, which is, should patients be taking ACE inhibitors and ARBs either prophylactically, preventatively, or not at all, depending on their effect on the ACE2 receptor? Well, needless to say, the last, I would say, 8 days have been incredibly confusing, and our view on this now has sort of morphed a little bit from where we were a week ago. A week ago, maybe 2 weeks ago, our thinking was ACE inhibitors and ARBs used in the short run might downregulate ACE2 receptors. These could be either preventative drugs that you would want to have in your system, or drugs that you would take once you were infected to reduce the rate of spread. We don't think that that's the case anymore. That said, it begs a clinical dilemma, which is, what should a patient do who's taken an ACE inhibitor or an ARB? And if you're watching this, you might be one of those people taking it. And if you're not, you almost assuredly know somebody who is. That's how common these drugs are. The European Consensus Guideline was just released recently, and it said sternly that the best recommendation is for patients on ACE inhibitors and ARBs to stay the course. And I understand why they made that recommendation, because of course, if we just said to patients, stop taking those things, your blood pressure would go up, and that by itself poses an independent risk for COVID-19. So the consensus statement is to take an ACE inhibitor if you're taking it, meaning if you've been taking it, take an ARB if you have. The only thing I would say to caveat that is, and this is something that I obviously can't tell any of you because you have to be able to discuss this with your doctor, but the discussion I would have with our patients is, if there is an alternative to an ACE inhibitor or an ARB that can allow equal blood pressure control without an interruption, it might be worth considering. But this is a big what if, because we don't really know how long after you stop an ACE inhibitor or an ARB, your ACE2 receptors revert back to normal. We don't know if there's a transient uptick in them before a downtick. I mean, there's so much unknown. And by the way, we don't know if this matters that much. Maybe these levels of ACE2 expression don't change that much and don't matter that much. And this is all a moot point. The reason I'm devoting a whole video to this is because, understandably, we're getting so many questions about it. And again, I think it's really helpful that the European consensus came out on this. I love that other people are looking at this, people who are obviously smarter than us. And so, you know, I would say if you're taking one of these things, you probably don't need to panic. But if it's causing so much distress, then I think you have to have that discussion with your doctor and say, you know, hey, is it possible that we could use other classes of drugs, you know, beta blockers, calcium channel blockers, you know, diuretics, hydrochlorothiazide, any of these other things that we can commonly use to address blood pressure. But I don't think the answer is stopping them because of the obvious consequences. And nor do I think it's to necessarily panic about this. My intuition is, and it could be wrong, this is not sort of a first order problem. So in the coming days, there are lots of other things that, you know, I'll look forward to updating folks about, but it's helpful, I think, to get feedback from people on topics that they want to understand better, because, you know, it might be that stuff that we've worked through and are already taking for granted in our knowledge base would be interesting to share with folks. Again, we'll continue to put out podcasts on this topic. I think we've got 2 scheduled. for this week, or I'm going on someone's podcast and having somebody on mine. And so, we'll continue to turn those around like in 24 hours or less if we can. And hopefully everybody's doing well. Again, I am still kind of optimistic here that, with the appropriate government response, which I see in many ways happening now. I see people taking this much more seriously than they were taking it a week ago. Again, I've made my gripe about testing, and I hope that issue is addressed. And then fortunately, there are, I don't want to say half a dozen, but maybe 4, 5 candidate drugs out there that are really interesting, that are obviously off-label and have other designations, but could be really helpful here. And perhaps in subsequent days, we'll have enough information to talk about those things.